Hi, and welcome to the Breastfeeding Medicine Podcast. I'm your co-host, Dr. Ann Eglash. I'm a clinical professor in the Department of Family Medicine at the University of Wisconsin School of Medicine and Public Health. I'm also a board-certified lactation consultant and a co-founder of the Academy of Breastfeeding Medicine.
And I'm Karen Bodnar. I am an assistant professor of pediatrics at Harbor UCLA Medical Center and a general pediatrician. I'm also a board-certified lactation consultant. And this podcast is sponsored by the Academy of Breastfeeding Medicine.
Just so you know, the content of our podcasts does not necessarily reflect official policies or protocols of the Academy of Breastfeeding Medicine. Are you ready to go?
Hey, Karen. How are you?
Ann. I'm doing great. How are you?
Pretty good. I guess we've been lucky. I guess we're going to talk about the weather again like we always do, but we don't have any flooding over here. And I hear that you guys don't have any water over there.
No, still not. It's so funny. So I am, as you know, moving to Virginia near Washington, D.C., and leaving beautiful California. And all the people here who I tell I'm moving either go, "Oh God, it'll be so hot," or "Oh, it snows there." And I'm like, yes, they have seasons.
But then you can tell them you can flush a toilet as much as you want. You can take showers as long as you want.
We should still conserve water in D.C., I'm sure.
Maybe, but I can tell you here, you don't need to conserve water. There's water everywhere.
Careful, you're going to get a nasty email from somebody who wants to be more environmentally conscious.
True. All right, well, today we're going to talk about birth control and the Academy of Breastfeeding Medicine Clinical Protocol number 13, which is titled Contraception During Breastfeeding, which was revised just this year and published in the Breastfeeding Medicine Journal, Volume 10, Number 1, so the first issue of this year.
Right. And this was primarily by Pamela Behrens and Miriam Labach and the Academy of Breastfeeding Medicine. And it can be found on the Academy's webpage at bfmed.org. There's a little protocol bar on the left. And I was really excited to see this new revision of this protocol because I had not read the protocol cover to cover previously, and it covers some important and complicated issues. The protocol is meant to help breastfeeding mothers to select contraceptive methods that are effective, that are unlikely to disrupt lactation, and to be satisfactory for her and her partner, and of course to help medical providers in assisting mothers with this. It covers contraceptive methods during breastfeeding and provides guidance on the lactational amenorrhea method, which I will sometimes call LAM for short.
Right, and I think the other thing that's nice about this protocol is that it clears up some of the confusion that people have, because people in lactation, like you and me, we know that there are negative effects when we give certain types of birth control to women when they're breastfeeding. We notice a lowering of their milk supply, but when you look at the World Health Organization and particularly the Center for Disease Control guidelines, they rely just on studies which we know which we'll talk about throughout the theme of this today, that the studies are not very good in terms of being able to clearly show that these hormones are safe during nursing. And so there's more of a comfort in using hormones if you go by the CDC guidelines, so that you'll have some physicians going by those guidelines saying, yeah, we can give Depo at 6 weeks, or we can give the birth control pill at 6 weeks and it's fine. Whereas the lactation consultants might, go, don't do that. And then there's this, clearly butting of the head situation, and patients get caught in the middle. So
I think it's been really tough because the studies have been lacking. There just aren't very many, and a lot of them are noted to be of poor quality, or they're just a lot of confounding factors. And when we talk a little bit about the physiology of lactation, it helps us to understand why people who work in this field have concerns.
Right. Great.
Okay, so I'm not going to talk about every single study that was mentioned in the protocol, and I really encourage people to read it because I think it does offer a lot, and there are some great charts in it that are worth looking at. But we're gonna touch on some interesting points. It starts off by making the point that contraception should be discussed during prenatal and postpartum visits, as well as at pediatricians' visits for the infant. And I have to say, I find this to be really important when I'm seeing babies, and they're 2 weeks old or they're 2 months old or, on up. We really talk about birth control at every well check, at least in the first year. It touches on a lot of considerations that affect women's contraceptive choice and advantages and disadvantages of available options. And just so people know, Table 1 provides useful information for counseling breastfeeding mothers, including potential for hormonal methods to disrupt milk synthesis, and talks about exposing infants to synthetic hormones as well. So I want to start out by reminding everyone that a falling progesterone level after birth is necessary for the onset of milk production. And thus, there are concerns about initiating hormonal contraception before lactation is established. We're going to start off and talk about the lactational amenorrhea method in the early postpartum period before other methods are used. And I think for me, reading this paper was really, really interesting because I've been a doctor for less than 10 years. And this method, although I had learned about it briefly, I hadn't learned about where it came from. And it grew out of data that was published in the 1970s showing that women were less likely to ovulate in the early postpartum period if they were breastfeeding. And further research showed that this method can be effective based on 3 criteria, which define the period of lowest pregnancy risk. The first one is no menstrual bleeding for greater than 2 days of duration, not counting any bleeding that happens in the first 2 months postpartum. Number 2 is full or nearly full breastfeeding. And number 3 is a baby less than 6 months old.
And the nearly full or full breastfeeding, I thought that was a little bit ambiguous. And so my understanding is that the woman is constantly nursing and not skipping any breastfeeds. And if she tops off the baby, let's say in the evening with some formula or something else, it's after she's nursed the normal number of times that she normally would be nursing.
Yeah, I think that's a really good way to put it. I think more in this setting about what I don't know if there's a better way to put this, but what the breast's experience of breastfeeding is rather than the baby's experience. And so the idea is that mom is going very few hours between emptying her breasts. And then there are some further studies that show that really as you get on to older infants, one of the things I used to always say is that there probably shouldn't be any breaks of longer than 5 hours at night, because some babies, even from a very young age, will sleep longer than that. And the studies have been done with this, some in particular, with no longer than 4 hours between breastfeeding during the day and no longer than 6 hours between breastfeeding at night.
Yeah, and they don't actually say that. Like, they don't define a period of time such that if the baby's sleeping, 6 or 8 hours and mom's not nursing all night, that would disqualify. But I think they're relying on her getting her menses back. And if she gets her menses back, clearly she broke through
right.
her prolactin level. And
so those numbers that I just cited were actually not from the original studies, but they were from 2 studies that were done later for to investigate whether or not this method would be useful beyond the baby's 6 month of life. And so one study was in Rwanda studying up to 9 months of age, and the other in Pakistan up to a year. And what I found was really interesting was they both found continued high efficacy of this method provided the mother continued to breastfeed at her same frequency, and that because after 6 months people are giving complementary foods, they did that after the baby was at the breast.
That the baby fed first.
Right,
yeah.
Exactly.
Mm-hmm.
And studies, the ones before this that were done in babies up to 6 months, consistently have found a pregnancy rate of 2%. So 98% effective if all 3 criteria are met.
Mm-hmm. Yeah, and I was going to mention, I think maybe you'll mention this later, but if you add the natural family planning that we'll talk about, then it seems to go down a little bit too, more to 1%.
Sure. And I think the other comment that I thought was really important with this is if a mother is not meeting any of those three criteria anymore, then her chance of pregnancy is increased and she should be advised to initiate another form of contraception. But the clinician should always be thinking ahead because mom needs to have chosen that next method of contraception before that day when she gets her period, because there's likely going to be a lapse of weeks or months between when she gets her period and when she next sees her clinician to talk about her birth control choice. So it makes sense to talk about it beforehand. I always joke with my patients that, in the first few weeks postpartum, they're told not to engage in sexual activity, and then, eventually they're allowed to, but they're still too tired. And when the baby finally does sleep for more than 5 hours and they wake up with energy, they don't think, oh, what contraceptive should I use? They think, hi, I remember you.
Yeah, right, exactly. Yeah, well, so I find, in my practice, that I cannot find a family that's willing to do the lactation amenorrhea method. They just don't feel secure with it unless they're comfortable with the possibility of becoming pregnant at that interval. If they say, I'm 36, I want to have another kid soon, I'm not going to use birth control, we'll see what happens. That's one thing, is that I don't think that many Americans have bought into the lactation amenorrhea method. And maybe that's because we haven't talked about it enough. They don't really, I think most families don't even know about it. Also, if I told someone that there's a 2% risk of pregnancy and the family wants 0%, they're not going to do it,
Yeah, absolutely.
And then,
that was me. I was not going, 2% was not okay for me.
Exactly. Yeah, exactly. It's not. And then the third issue is that I feel like the nutritional status of women in the United States is very different than it is among women who took part in these studies in other countries back in the 70s through the 90s. And so, and I don't feel that we have very contemporary studies with women who have high BMIs, who are very well nourished, because I feel that I see a lot of women who do get their menses back before 6 months and they're fully nursing. They're nursing constantly and they're getting their periods back before 6 months. So nutritional status in women needs to be evaluated as well. And then many women take things like Shatavari and Gotru, which both can enhance fertility. Even though they are helpful for low milk supply, it's kind of paradoxical, but they do enhance fertility. And so there's that risk as well. So I think we have to be careful with, the lactation amenorrhea method. I think the big thing in my mind, and we'll talk about the mini pill, which is the progesterone-only pill, but if you add that to fully nursing, women don't need to really worry about the mini pill in and of itself being not the combined birth control pill. We always think of the combined birth control pill is your gold standard for birth control. You're not going to get pregnant if you take it properly. The mini pill, there's a higher risk of pregnancy, but if you combine that with lactation amenorrhea method, and you're just nursing the first 6 months, and you take the mini pill, that's pretty hard to get pregnant doing the two things. So that can be reassuring for women.
It is. And then a final thing that I learned reading this protocol was that, these studies that were done evaluating the effectiveness of LAM were not with hand expressing milk or pumping, and so those have not really been evaluated. Women who are expressing more than a few times a week should be counseled that this may not be as effective. We really just don't have any data on it.
Right. Yeah, because their prolactin levels are not necessarily going to be as high, which I see all the time with women who are just pumping for their preemie, or they're going back to work and then they are just pumping and their supply goes down. And so basically the lactation amenorrhea method is not considered valid for anyone who's who's separated from their infant and working outside the home.
So those moms need to be advised to initiate an additional contraceptive method.
Yeah, if they want that, yeah. Yep.
So then the paper goes on to talk about natural family planning, and I didn't learn in medical school that there are 4 different methods of fertility awareness, which together are frequently called natural family planning. They rely on observation of things like cervical mucus, body temperature, or other hormonal monitoring, and they require significant periods of abstinence when a woman realizes that it's around the time of ovulation. And these are discussed in more detail in the paper.
Yeah, it would seem to me that the natural family planning method has to be a little bit tough when you're nursing the first 6 months, because it's hard to see any kind of ovulatory pattern, because you shouldn't be ovulating unless you're working. Yeah.
And the paper does mention that the pregnancy rates were elevated among breastfeeders after menses returned who were using this method, as opposed to women who were not lactating who were using this method. It was about 36% as opposed to 13%. And this did not appear to be due to differences in their use of the method. They just had increased risk.
Yeah, they probably couldn't track their ovulation
very easily. Yeah, they're probably exhausted.
And it's probably irregular.
Yes.
The ovulation's irregular because they're nursing. Yeah.
Yeah, that probably is true. Mm-hmm. So I thought that was really interesting. And I think what's really brought home to me by this is different people have, like, I was not comfortable with 2%. There are people who are like, yeah, I'm not really trying to get pregnant right now, but if it does happen, that's okay. And they may choose these methods with lower efficacy. I think it's just really important to be able to help moms understand what the differences are.
Right, exactly.
So then we go into hormonal contraceptive methods, and there are quite a few different ones. There is controversy in the literature regarding hormonal contraceptive effects on milk supply, and that's because while one study reported an increase in milk supply, another showed a decline in milk supply with progestin-only contraception versus placebo, and a bunch of different studies have found no effect. And so we're going to talk a little bit about the different forms, but essentially the evidence is inadequate to make really evidence-based recommendations regarding hormonal contraceptive use for lactating women, and thus we fall back a lot of times on knowing the effect of estrogen on milk supply and the importance of allowing progesterone to drop in the initiation of lactation and those sorts of things.
Right, exactly.
And I would say that the authors note that hormonal methods should be discouraged in situations where the milk supply is already borderline, could be difficult to establish, like when the baby is in the NICU, or when greater milk supply may be needed, like with multiples. Mm-hmm. In short, for reasons we've already alluded to, estrogen-containing combined hormonal contraceptive options are not ideal for early postpartum breastfeeding mothers because of this potential adverse impact on milk supply. And the fact that I mentioned about the importance of progesterone dropping leads me in to talk about the progestin-containing contraceptives. So the mini pill, which you had mentioned, there are also implants like the Implanon or the Nexplanon, the Depo-Provera injection, which is given every 3 months, or the Mirena intrauterine system. And I think that there's been a lot of controversy around using these, and also in the timing of using these.
Right.
So I don't know, do you want to talk a little bit now about the progestin?
Yeah, let's talk about there's a couple of different ways of talking about this. We can talk about the progesterone only methods. Let's talk about that first.
Okay, sounds good. So essentially there is the methods in general are very effective. And so I think that a lot of people use these. It varies a lot by country. So for instance, the Mirena IUD, which is used in the single digits in the United States, is used in 80% of women in some countries, can be very, very effective. And I think that compared to, in my practice, when I'm talking to people about hormonal methods, using progestin only contraceptives compared to using a combination oral contraceptive pill, I consider it to be less likely to have a negative impact on milk supply.
Right. Yeah, I totally agree. But the timing of the progesterone is the issue.
Absolutely. That being said, there was a direct comparison of progestin-only pills and combined oral contraceptives that didn't show a very big impact or a very big difference between the two on milk supply. And so I think this really highlights the difficulty in doing these types of studies. You know, some of the studies, they'll say, oh, this many women discontinued the pills because they thought they had an impact on their supply, or this many women stopped breastfeeding in this group versus the other, or they'll even try to estimate the amount of milk transferred using
the nuclear
deuterium, the heavy water, which is really fascinating that somebody has gone to all this effort to do these. But despite doing all of that, we don't necessarily have a really good answer.
Right. Well, and I think sometimes it's how this is measured, because I think that the studies showing the amount of milk that the infant takes, that's probably a pretty good way to measure, the effect of the hormone on milk supply. But on the other hand, if a woman had a high supply and then it dropped considerably from the hormone method, the baby still may be able to take enough milk, but her supply may have dropped quite a bit. Mm-hmm. And that's particularly true. I see that a lot with women who have a high supply and they get a double shot or the birth control pill with estrogen. They drop their supply, but they oftentimes can remain fairly well matched.
Yeah, and there are some people who would probably do well with a lot of obstacles, and there are those women who we meet who, even with a great deal of support, always struggle with supply. So what's going to happen to an individual patient can be difficult to predict.
Right. But I think in general, the World Health Organization and then Center for Disease Control agree that the mini pill is certainly acceptable and safe for mothers who are 6 weeks postpartum.
I absolutely agree with that.
The problem is the injectables are, they say the same thing for the injectables as well, that they're safe after 6 weeks, which I think many of us in lactation would really question whether or not a shot of Depo-Provera would really be safe for milk supply after 6 weeks, because I think many of us see a drop.
Yeah, and I think that the feeling that I have is that it hasn't been well studied, in that the big study that said there's no difference was done in mixed feeding dyads. And so it wasn't with exclusively breastfeeding moms, and so I think it's harder to tease out what the effect was in that study. Also, another study of low-income mothers who were given the injectable found that 60% of those who were given it prior to hospital discharge. And so I think that particularly in low-income mothers, this is very frequently given in the hospital because of providers' anxiety that there's going to be very closely spaced pregnancies.
Right. And so if we actually look at the recommendations from the World Health Organization, they actually say do not use injectable, I take that back. They say they level it a number 3 out of 4. So they rate these contraceptive methods 1 through 4. 1 means absolutely go ahead and do it. Number 2 is it's probably fine, don't worry so much about it. Number 3 is, well, I guess you can do it, but there's a lot of negatives. And 4 is don't do it. And so they actually give something like Depo, they label it a 3, meaning there's some definite risk, but you might have to do it for between birth and 6 weeks. Whereas the Center for Disease Control says under a month, they give it a number 2, like it's probably okay. And I think that's the crux of one of the issues that we have, is Depo being given under 6 weeks. Is that really safe or not? And like you said, there aren't good studies, and we know physiologically that we need to let that progesterone drop to bring the milk in. So I think the problem here is that that a lot of the providers who are giving that Depo under 6 weeks don't understand the importance of doing informed consent with mothers to explain to them, look, you have a risk of a drop in milk supply. And that's with these ratings of 3 from World Health Organization and 2 from CDC, that's saying those ratings are saying to the providers, look, there's a but in giving that. We're saying to you, look, it's okay, but, or it's maybe okay, but, and then that but never gets shared.
I absolutely agree. I think people just are very paternalistic, going from room to room, giving everybody a shot, and not really discussing the risks and the alternatives.
Right. But on the other hand, this information from the World Health Organization and from the CDC, well, the World Health Organization isn't as guilty about this as the CDC, doesn't really emphasize this enough to providers when they look at the chart. And so they don't even really consider that the issue very much for mothers. And so we really need better studies to be able to say with determination, this is not a good idea.
Yeah.
I want to mention about the IUD, though, because it's becoming more acceptable to insert a progesterone IUD or a copper IUD immediately postpartum, right after the placenta is delivered. And I think many people are hoping that by putting that IUD in right away, like the Mirena IUD, they don't have to worry about the negative effects of giving Depo on milk supply that is such a small amount of progesterone. So they do mention that there was one study done on that, and that was done in Pittsburgh published in 2011 in the journal Contraception, and the authors were Chen, Reeves, Kreinen, and Schwartz. And so what they did is they recruited women who were interested in a progesterone IUD after birth, and they randomized them to IUD insertion either immediately postpartum or at 6 to 8 weeks. So women had to agree to just be randomized. So 50 received it postpartum and 46 received it at 6 to 8 weeks. But what's interesting about the study is that they had really low initiation rates. Only 64% of the mothers who received it postpartum initiated breastfeeding. And only, and only 58% of mothers who received it later initiated breastfeeding. So these were not like super highly motivated women. But on the other hand, when you look at the demographics, like 60+% of these mothers were were college educated or beyond. So that was an interesting. That was surprising. And so the bottom line in this study is that the women who received it at 6 to 8 weeks breastfed longer than those who received it immediately postpartum. And you saw them really drop off over time more and more. So for both groups, the number of women who were breastfeeding really declined a lot by 3 months. So for those who were given the IUD later, 28% were nursing at 3 months. And only 20% of mothers were exclusively nursing. And for the ones who got the IUD right away, 14% of those were nursing at 3 months, and only one of the moms, which is 2%, was exclusively breastfeeding. And then at 6 months, the mothers who got the IUD at 6 to 8 weeks were only 23% were still nursing at all, and only 6% of the women who got the IUD postpartum were still nursing. So one of the problems with the study is that if they didn't ask the women about their milk supply or how much supplementation they were giving, they just said, are you nursing or you're not nursing, period. When did you stop nursing? And that's the problem with a lot of these studies. And, this was done in 2011, and by then, we had Miriam Lack's studies on, or recommendations on defining breastfeeding.
How to do a good study that involves breastfeeding.
Right. And I wonder if this design was patterned after some of these really old studies where it was the same sort of thing, like, are you breastfeeding or not breastfeeding? And not really getting the lowdown on exactly what the issue is. Especially when you get that far out, I think, it's important and significant to know, like, what percentages of those women are still staying home and what percent have gone back to work. And because that affects, other reasons why they would have had lower rates. Right. And if you do the same sort of study back in the 90s and you say, okay, you still nursing, well, 28% at 6 months, okay, maybe that was really good. and then women who didn't have any hormonal intervention, that's all they were nursing as well, because we had lousy support back then.
Yeah.
So then you're comparing, women who, maybe they would have had better intention, who knows? So yeah, this whole thing needs to be redone, basically.
In Oregon, where there are really good rates and good support.
So, so the bottom line is that from this one study, it does appear that having the IUD put in immediately postpartum has a much bigger impact on duration of nursing. We don't know why. Maybe it's lower milk supply. We don't know why. But otherwise, the groups were pretty similar in terms of demographics. So I would say that jumping onto this bandwagon of just assuming, well, it's a lower amount of progesterone, women are going to do fine, you're putting the progesterone right back where you got it, basically. So
yeah.
To me, that does not seem to be a good idea based on this one study at this point.
That's fascinating.
Yeah.
Yeah, I think there's a lot of future research potential.
Absolutely.
So when I went on to read about estrogen-containing combined hormonal options, I was reminded that there are a lot of them. There are, of course, the combination oral contraceptive pills, the transdermal patch, or combined contraceptive vaginal rings. And these are not ideal for early postpartum breastfeeding, particularly because of potential adverse impact on supply. And I think it's worth reminding people who don't remember this that we know this is able to cause milk suppression because historically large doses of estrogen immediately postpartum were used for lactation suppression prior to our understanding of the elevated thrombogenic risk during that period.
Right. When I was in my training in the 1980s, we were given, standard orders for women postpartum, and every woman, because hardly anyone nursed back then, we checked off whether or not we were going to choose estrogen, hydrochlorothiazide, testosterone shot, or bromocriptine, which at the point we used to call it Parladel. Which one do you want to give the woman for drying up her milk? Period.
It's unbelievable now. Yes. And it's fascinating to hear you say that because when I was a medical student, remember going and seeing a mom, and her mom would be there, and I would be like, oh, well, did you breastfeed? She's like, no, they gave me the shot. And I didn't even know what she was talking about.
Right, that's the history of that.
I was like, what shot did they give her?
Yeah.
And I didn't really make the connection at that time that it was because, well, one, we were trying to encourage breastfeeding, but also it was really dangerous to be giving high doses of estrogen at that time.
Oh, yeah, we used to watch people, there were several cases of women who just, fell over dead, from a huge PE, at postpartum. They'd be walking down the hall postpartum and they're dead,
Pregnancy is dangerous enough without us doing that.
Exactly. Yeah. Yeah. And then I trained with an Amish population, and they would see us coming and saying, with the nurse saying, well, we're going to give you this medicine to dry up your milk. And they would put their hands up and say, I'm breastfeeding. And then that woman is treated differently, and no one talks about the feeding. No one helps the woman feed. She just says, I'm breastfeeding, and suddenly she ends up in a different category of okay, she has something special going on. We're not going to do routine things for her.
Wow.
Yeah.
And my experience also with this in my personal practice is that occasionally we give estrogen-containing pills to women who have really significant oversupply to try to bring their supply down. I don't find, thankfully, many of my patients being given, many of my breastfeeding patients being given combination oral pills by their OBGYNs, sort of they're not thinking about whether or not they're breastfeeding. I don't find that to be the case in my practice. I think usually when I talk to women at their postpartum visit or it's their well visits, and I'm like, oh, what are you planning? They'll say, oh, I got a prescription from a pill from my OB. I still always check and look and say oh, have you filled it? What's the prescription? Just to make sure. But I think that in general, people are giving the so-called mini pill because they're aware of that issue.
I think it's regional. because we have a OBGYN training program, they're very aware of most recent guidelines. And so the most recent guideline by the Center for Disease Control for combined oral contraception is under a month, it's a 3. So it's not a 4. It's a 3, meaning,
Wow.
well, you can give it, but just be careful. And
Yeah.
then after a month, it's a 2, meaning it's probably fine. Just be, aware of possibly a decrease in milk supply.
I find that shocking.
Yes, and so I've been seeing more combined oral contraception being given to mothers at the 6-week mark because they're being told, "Oh, studies show it's fine,"
Wow.
and they're not told this could drop my milk supply, and so they're trusting their OBs. And so I'm seeing this in my lactation clinic, where patients are saying, "Well, I never knew that, and I'm so upset that no one told me this."
That's fascinating.
Whereas the World Health Organization states that between 0 and 6 weeks, it's a level 4, like don't give it. And then between 6 weeks and 6 months, it's a level 3, like not a good idea, if you have to give it. And then after 6 months, it's a 2. So they wait until 6 months.
This, to me, sort of makes me think back to the need for better education in pharmacy schools. Like, I think, you'll be told that you need to stop breastfeeding for your Z-Pack that you're taking, but nobody will mention to you that this thing that could totally ruin your breastfeeding is a possible problem.
Right. Well, I wish that the World Health Organization information was distributed rather than the Center for Disease Control information, and I think it's really sad that they differ so much. Mm-hmm. And personally, I use the birth control pill with estrogen for women with a high supply, and I think it works really well at any time during lactation, whether the mother is 6 weeks, 12 weeks, 9 months, or even 2 years postpartum. Giving the birth control pill with estrogen drops the supply. Just like when a woman becomes pregnant, it drops her supply. That's when. So, it just makes, it's kind of funny because here we're stumbling over these studies, yet it just makes physiologic sense with all of this. In terms of, the placenta delivery, dropping the progesterone level, and then having a woman become pregnant, her estrogen goes up, and lo and behold, her milk supply drops. It all is just natural. It just makes sense. We understand that physiologically, but then when you talk about interrupting that natural process with giving hormones, suddenly it's like, oh, we have to study that to prove that that's the case. And, so
Sure.
it's frustrating because I think a lot of women don't have, they suffer from it. So.
Yeah, and this is one of the more complicated areas to me about, I think endocrinology in general is sort of complicated. I think a lot of people, after they've left their medical training, sort of forget some of those pathways that they've learned. And so if this isn't something they deal with all the time, they may not really have that in the forefront of their brain of how those different things you just described work.
Right. Well, and I think that the whole physiology of lactation is not quite understood. The reason why the milk comes in is because of the drop in the placenta. I don't know if I would have known that had I not been a lactation consultant. As a family doctor, I don't know if I would have even thought about it.
Oh, I remember learning about it in medical school, but, some people probably weren't paying attention that day. So I'm not saying that you were one of them. Emergency contraception, just to change the subject, is touched on in here. And, interestingly, also, there are a lot of choices. And so you can have post-coital copper IUD placement, combined oral contraceptive, progesterone-only options, or mifepristone. Am I saying that correctly?
Mm-hmm. Yeah.
Which that is not something that I've ever done. I've only ever used the combined or progesterone-only options. And really, this was very interesting to me because the IUD placement, being copper, is unlikely to impact lactation, and it has an advantage of providing, long-lasting contraception. The progesterone options are slightly more effective than the combined estrogen-progestin options, and they're also less likely to cause nausea and vomiting, which can be very significant for some women who are looking for emergency contraception.
Yeah. It's really not fair to make them vomit
No.
after they've had sex. It's really just not right. Yeah, I mostly use the progesterone emergency contraception. That's safer with nursing.
Absolutely. And I think that, interestingly in here, it mentions that this method, emergency contraception, has been evaluated as a backup to the lactational amenorrhea method. And although, this isn't necessarily something that we want to be encouraging women to do frequently, I think that sort of that thing that I alluded to earlier of people aren't always thinking ahead about when they are no longer going to be meeting all the criteria for the lactational amenorrhea method, having a prescription on hand before you need it is really important.
Right. Absolutely. Yeah. I want to mention one other thing about the copper IUD and about insertion of IUDs. And the recommendation from the World Health Organization and the CDC is that the copper IUD is safe to put in immediately postpartum. But once you get towards, the World Health Organization says once you wait 48 hours into the fourth week, from day 2 through the fourth week, you have a higher rate of uterine perforation. And the CDC says something similar, like if you wait more than 10 minutes after placental delivery until 4 weeks, you have a higher risk of perforation. But putting that in immediately postpartum is probably going to be that's going to be the ticket, really, to not inhibit lactation and safe long term. And they can leave it in for 12, 15 years if they don't want to have another baby. So that's what I'm, advocating for, is the copper IUD.
And I think, the downside is that in theory it can cause more irregular bleeding.
It's more cramps and heavier bleeding.
Yeah. And so this really goes back to the beginning when it's, what is going to work for that mom and her partner? Because if you're not going to stick with the method, then there's no point in handing out that prescription. I mean, a lot of the moms are like, yeah, I have this prescription, I haven't filled it. Like, okay, well, how this baby that you're holding got here, right? Let's, especially in my younger patients. And as an aside, these longer lasting birth control methods are becoming more and more recommended as choices for teenagers to be effective, long-lasting methods for them.
Yes, there's a new progesterone IUD called the Skyla that's a little smaller for teenagers who haven't had babies yet. So I've been seeing a lot of those being put in.
Oh, I'm glad to hear that. So we can talk just very briefly about barrier methods. The condoms, for example, also diaphragm there are no known adverse effects on lactation, but patients should be counseled that they have reduced efficacy compared to other hormonal, intrauterine, or permanent options.
Yeah, the diaphragm's a little bit tricky because women have to get refitted after they have a baby.
I did not know that.
Yeah. Well, so I come from a generation of lots of diaphragm users. And we did a lot of fittings. I mean, that was one of the best methods years ago. And you have to be fed every time you have a baby. Or if you lose or gain 10 pounds, you have to be refitted for your diaphragm.
Oh, wow. Yeah, that doesn't sound like a method that I would really prefer.
Right. Yeah. I think I'm actually on Earth because my mother didn't use it properly. She said, "Oh yeah, I have that diaphragm, but yeah, I didn't really." Yeah, that's how that happened. So.
And then finally, the irreversible options, sterilization, are discussed, including male vasectomy, postpartum tubal ligation, laparoscopic tubal ligation, and hysteroscopic tubal occlusion. And these procedures involve different technologies, surgical techniques, anesthesia, and procedural settings. And I think that an important consideration for breastfeeding has to do with the potential impact of early maternal-infant separation. And also this is related to a problem that we have in many hospitals in this country where there's inadequate education of providers about the safety of nursing after moms are given anesthesia.
Right.
So I'll see a mom who, she's going for her tubal, and then she's told she can't breastfeed for 24 hours because she was given anesthesia. Whereas we know with the inhaled anesthetics, as soon as the mom is awake and alert enough to safely hold and nurse her baby, it is safe for the baby to have the milk.
Which is so funny because, when women wake up, if they have general for their C-section, they wake up and they nurse.
Yes.
So it's the same thing, but everyone knows that that's okay. But then after other procedures, they don't know it's okay. So
yes, absolutely.
Yeah. All right. I think we finished that one pretty well.
We crushed it.
Yeah, we crushed it. I'll put a link on our Facebook page for that protocol so people can find it. All right, Karen. Well, take care and and good luck with your move out east.
Thanks.
And we'll be in touch soon.
Sounds good. Bye.
Okay, bye. If you have any interest in the Academy of Breastfeeding Medicine or any questions or comments about this podcast, please email us at abm@b as in boy, f as in Frank, med.org. Thanks for listening. We'll see you in a few weeks.